to the cloud. All right, so welcome to your HESI review. Again, this is obviously being recorded. Um, it will be posted in the shells, as well as other instructors will also be posting their power or their HESI reviews. So you will have more than one. So there'll be multiple. I think there's four, one, two, there's four of us. They'll all be posting their HESI reviews in there. So, excuse me. I'm going to share my screen. I'm trying not to sneeze. I know it looks like I'm yawning, but I'm like trying not to sneeze on my computer and all of y'all. Okay. So I'm going to share my screen. All right. Um, all right. Sherrod, I think you're on here twice, just to let you know. Let me see. Can you hear me or not? All right. So everybody can see my screen. All right. I'm not sure what's going on with Sharada. Okay, there you are. You were on there twice, Sharada, and then I didn't know what happened, but well, all right. Alexandra, throw your last name on your Zoom for me. So again,
You
Hesse,
said I should put.
put your last name on
Oh,
there.
okay, okay, okay.
Um, yeah. So remember when you're answering your questions, always use your nursing process, right? So in analysis, planning, implementation, evaluation, what other things? So you guys have seen these, maybe, how many of you use something like Saunders or something to help you study? Anybody use Saunders? Any of the NCLEX prep? So you can do like review questions in Saunders. These are the clinical judgment measurement that is part of your NCLEX. It's the clinical judgment model. And it breaks it down into categories. So the categories are recognizing cues, analyzing cues, prioritizing hypotheses, generating solutions, taking action, and evaluating outcomes. So these are some of the things that you will see on your HESI. And you guys have taken HESIs before. Um, Client needs categories. These are safe and effective care, coordinated care, safety and infection control, your physiological adaptation, your psychosocial integrity, um, and your reduction of risk. Nursing concepts. So the nursing concepts that you have covered throughout this course, and even some, other courses leading up till now, professional behaviors, clinical judgment, nursing interventions, quality improvement, evidence-based practice, collaboration, teaching, health policy systems, care coordination, and your ethical and legal concepts. Always consider safety, scope of practice, and your organizational rules and policies, right? So those are the big things, right? Always worry about patient safety, always concerned, making sure that you're practicing within your scope of practice. Uh, excuse me, and then following the organizational rules and policies. So again, topic safe, effective care, management care. So under safe and effective care environment, when to note, we're going to go through more, there's more in depth, but this is just the overview. When to notify or contact the healthcare provider, the different levels of precautions, your contact, your airborne, your droplet, hand hygiene, what to do with client refusal of care, HIPAA and confidentiality, client mobility, cane walk, wheelchair ambulation, advanced directives. What's an ambiguous prescription? Is it weird? What's ambiguous mean? like you're unsure, like it's missing pieces, right? So remember with prescriptions, there's certain parts of prescriptions that have to be present in order for that prescription to be filled, right? Patient's name, patient's date of birth, the date of the prescription, the medication, the dose, the route, the time, the frequency, right? It has to be signed by the provider. And if we don't have all of those parts for an order, right? Let's say you have a prescription for Lasix 20 milligrams daily. Is that a full prescription? What's missing?
It doesn't tell you the route.
Right, doesn't tell us the route, right? So that would be an ambiguous prescription, right? We would have to go back to get clarification from the order. We don't ever assume. Medication administration, client preferences, positioning, following up, evaluation, medication errors, medication teaching, skin integrity, conflict resolution, and then management of care. We have prioritization of care, continuity, assignment, delegation, communication, supervising your UAPs, teaching and evaluation, client staff refusal of care, client complaints, proper equipment, plan of care, quality improvement, ambulation, missed care, your legal and ethical is your Nurse Practice Act, colleague reporting, medication error, documentation, sentinel event, organ donation. What is the first thing that we do when we realize we make a medication error? Doesn't matter if it's a vitamin C or a Percocet. What is our first responsibility
Don't you need to report it to the supervisor
before we
and
report it to
document?
the supervisor?
You check the vitals.
Check your patient, right? Assess your patient. Assess your patient. Yes, absolutely. Um, what's a sentinel event?
Ain't the central event is like the Good Samaritan Act?
Good Samaritan
No.
Act. Sentinel event is an unexpected occurrence, right, that results in death, permanent harm, or severe temporary harm, right? So this could be a medication error, could be a fall with an injury. Oh, um, my allergies are really bad. Um, right. So things that we don't want to happen. Organ donation. What else? Client assignment, scope of practice, client record access, your Good Samaritan Act, phone prescriptions. All right, so uh, thinking like a nurse, strategies for being successful in nursing tests. Here we go. So step number one, when you're reading a question, look at the question type and the topic, right? So that's always a big one, just like when you're taking your tests and course in the class, right? You want to look at the question, you want to figure out what it's asking and what you know. So you want to, I always say if somebody is, if you're one of the best things that you can do, let's put it this way, is when you're reading a question, don't look at the answers. Read the question and then try to formulate the answer in your head. And then look at the answers and see if there's an answer that's close to what you were thinking. Um, you want to also decide, is it something that you need to assess or is it something that we need to implement? Remember, sometimes it's not always stopping and assessing, right? We may have to do something. Step three is Maslow's. Is it a physical versus a psychosocial need? And then we have the spec. All right. So, especially with prioritization of care, right? When we look at who we need to see first, we want to look at stable. Are they stable or are they unstable? Is it a potential threat or is it a real threat? Is it an expected outcome or an unexpected outcome? And is it chronic versus acute? All right. And then always then your ABCs. Oops. Other strategies, oh, I don't know why this isn't okay. Other strategies, you can use imagery to visualize the client situation. You can look at their vital signs, their labs, determine whether the assessment was normal versus abnormal. Timing, right? New admission from the ED, transfer from the ICU, immediate post-op, 2-day post-op, ready for discharge, right? You need to really look at that part of the question as well when you're looking at, who you need to go see. Age, growth and development. First does not always mean assessment, right? And actions don't always mean implement. So, for example, right, you walk into your patient's room and they are short of breath, right? What's the first thing that you do? Elevate the head of the bed, right, Tasha? I saw
Yeah.
your hand going.
Well, I
Okay.
didn't realize I was muted.
Right? But you didn't stop to listen to lung sounds or do their pulse ox, right? You just went in and elevated their head of the bed, which is the right thing to do, right? Somebody is short of breath, right? So first doesn't always mean assess. And actions don't always mean implement. Oh, my mouse is stuck. All right. We all know Maslow, right? The highest priority are those physiological needs. The second highest priority is safety, right? So if you're reading a question and you are torn, remember that the physical needs will take priority over the psychosocial needs, right? So those physiological needs are going to be first: food, shelter, clothing, right? And then your safety and security needs. Um, Another way to think about ABC safety, pain, and then education, well-being, coping, and normal findings. Pain for HESI is usually considered psychosocial. Um, Here's your ABs: airway, breathing, circulation, safety, who's going to die first, right? So another way to think of it, right? Especially when you're looking at prioritization of care, right? Who are you going to go see first? All right. Recognizing expected and unexpected behaviors, right? To prove minimum competency, a beginning nurse must demonstrate the ability to make appropriate nursing judgments, right? So you need to be able to recognize both expected as well as unexpected outcomes. Outcomes allow nurses to evaluate whether the goals have been met, right? And we know that, right? Because that's part of that nursing process. So when you're looking at these questions, you're going to look, what is the expected outcome of your action? So like that person that you walked in and they were short of breath, right? Because they're laying flat. You go in, you elevate the head of the bed, right? The goal is, right, that they should be able to breathe a little bit better. What is or then you can always look at what is the best action for the expected outcome. So vice versa, right? Do you have someone that has chronic shortness of breath, right? What are the best actions that you would take, right, for that client? Will it help or hurt in this situation? So again, it's really important to make sure that you're reading the question, that you're identifying what the topic of the question is. Is it desired? Is it the credited answer? And the other, if you could only do one thing before leaving the room, what is it going to be? And then, the outcome is used with every question. All right. So here we go. Which client complaint? There's too many C's and S's. Which client's complaint of pain should the nurse respond to first? So we have a client who's complaining of 1, bladder spasms after draining 1,000 mLs of urine during insertion of an indwelling catheter. 2, flank pain that is partially relieved after passing a renal calculus. 3, bladder pain while receiving a continuous saline irrigant 2 hours after a transurethral prostatic resection. Or 4, incisional pain on the 3rd day post-nephrectomy requesting a PRN oral pain med. So, which client's complaint of pain should the nurse respond to first? So if we have to go back, I'm going to go back a couple slides real quick. Where'd it go? All right. So use your stable versus unstable, potential versus real, expected versus unexpected, chronic versus acute, and then your ABCs. So I'm going to go back to the question.
C or 3.
3.
Yeah, I was thinking 3 too.
All right. So, ta-da. Very good. So let's go through it. So bladder spasms after draining 1,000 mLs of urine during insertion of an indwelling catheter. That is stable. It is real. It is expected. It is acute, right? Hit that 1,000, you're liable to get some bladder spasms. Flank pain that is partially relieved after passing a renal calculus. That is stable. That is real. That is expected. It's acute. Bladder pain while receiving a continuous saline irrigant 2 hours after a TURP or a transurethral prostatic resection. It is stable, it is real, it is unexpected, and it is acute. And then incisional pain on the 3rd day post-nephrectomy requesting a PRN oral pain medication, stable, real, expected, acute. You just took my kidney out. That's going to hurt, right? It's probably going to take more than 3 days for me to feel a little bit better, right? Same thing, right? We pass a kidney stone, we expect them to have a little bit of pain. All right, the practical nurse is evaluating a new client's risk for osteoporosis who has recently moved into an assisted living community. Which task should the PN assign to the unlicensed assistive personnel? So 1, take weekly height and weight measurements. 2, review medical record for disease history and compare findings. 3, perform full range of motion of all extremities. And 4, inspect and palpate the client's vertebral column from neck to hip. So we have a new client's risk for osteoporosis who has recently moved into an assisted living community. Which task should the PN assign to the UAP? Which of those can the UAP perform?
1 and 3. They can do.
Okay. So I have 1 and 3. Anything else?
Is this a select all or
It is not.
not? So 1.
So yes, so they can take weekly height and weight measurements, but 2, reviewing the medical record for disease history and comparing findings, performing full range of motion of all extremities, and inspecting and palpating the client's vertebral column are not within the scope of practice for the UAP. Active listening. You guys remember active listening, right? So the different parts of your active listening. Restating is just repeating what the client said or the client stated in a slightly different way. Clarifying is asking questions to be, in response to patient statement to be sure that you understood what they're saying. Reflecting is putting into words the information you receive from the patient at an effective communication level. Paraphrasing is expressing in your own words what you think the patient means. Minimal encouraging, those are the sounds or words to encourage the patient to continue, like go on, keep going, tell me more, that kind of thing. Silence, right? We know silence can be uncomfortable for some. However, it is an effective part of listening. Lots of reasons why, silence, it works to help people gather their thoughts, right? Sometimes people need just a minute, after receiving, bad news. And then summarizing is saying the main data that you have gathered, which then allows for validation, right? So you summarize the information that you received from the patient, you repeat it back to them, and then that allows the patient to correct any information or say, yep, you got it all right. Negative communication, why questions, right? Those are great for toddlers. But want to be really, you don't want to use the why questions. You don't want to offer false reassurances like, oh, don't worry about it. It's going to be fine, right? It's going to be okay. Don't need to worry about that. Probing, probing is, digging in, it's getting, it's asking questions, that is outside of things that we need to know. It's more of just being nosy. Judging, we don't ever judge our patients. We may not agree, right, with their, what they're doing, or what else? Yeah, I mean, we don't, we're not agreeing with what we're doing, but, we don't judge them. We want to maintain that therapeutic relationship. We never belittle, right? So you don't mimic, you don't make fun of your client, whether it's in front of them or even behind their back. And we don't give advice, right? So this is something you have to be really careful with. You're going to get this, what would you do in my situation? Or what do you think the best option is? It is not our decision. It is not our choice, right? We want to make sure that our clients have all the necessary information to make an informed decision for themselves. All right. So the practical nurse is observing a UAP, provide care for a client in an assisted living community. Which action by the UAP should the PN determine is safe for the UAP to continue? 1, accepts a verbal prescription from the healthcare provider. 2, obtains vital signs for a client who takes blood pressure medication. 3, assesses the stage 2 ulcer on the coccyx for signs of improvement. Or 4, gives an initial dose of antibiotics to a client with a fever. What is within the UAP's scope of practice?
Two.
Vital signs.
Absolutely. They can't take a verbal prescription from a provider. They can't assess a stage 2 ulcer, and they cannot give an initial dose of antibiotics. Good job. All right. The practical nurse is emptying a client's urinary bedside drainage unit. Which component of the nursing process is the PN using? Analysis, implementation, evaluation, or assessment. So we're emptying a client's urinary bedside drainage unit. What part of the nursing process is that?
Wouldn't that be the assessment? Because you're going to be looking at the color, the clarity, measuring, or is it analyzing?
I say 2. I don't know.
Okay. All right. Well, let's see. It is implementation because we are doing something. It says emptying. Doesn't say we're looking at it for any other reason, just empty in the bedside drainage unit. Okay, so that is an action we are implementing. All right, here we go. Who do we see first? So we have Harry, who is 88 years old. He has a bowel obstruction. He vomited 100 mLs of bile colored and vomited 100 mLs. It is bile colored, and NG tube is ordered. Naomi is 38 years old. She has appendicitis. Her pain is 7 out of 10, and her temperature is 102.7. Peter is 15 years old. He has Crohn's disease, frequent watery stools. His blood pressure is 95 over 50 millimeters of mercury. Or we have Pam, who is 59 years old, in liver failure. She is jaundiced and confused. So, who do we see first?
Would it be Peter?
Naomi.
Peter. I got a Peter and a Naomi.
Naomi.
I got another Naomi. All right. One Peter and two Naomis. Anybody else? All right. So we are going to see Naomi. Why are we going to see Naomi first?
Because
She
of
has
her pain and her temperature.
high temperature, potential infection.
Potential, right? So I have appendicitis and my pain is a 7 out of 10 minimum. It's 7 out of 10 and my temp just rose. Or maybe it didn't just rise, but it's at 102.7, right? So infection is key. What happens if that appendicitis or appendicitis? What happens if that appendix bursts, right? Then we're in the risk for peritonitis, right? And sepsis and all that wonderful stuff. So good job. What is or are the most common reasons that a new grad loses his or her license? This is a good one. Failure to notice or recognize, failure to act or respond, or failure to report or communicate. What is the most common reason a new grad loses his or her license?
Was your reporting communication?
Failure to report.
Failure to report. All right, let's see. It is failure to report. All right. Excuse me. Principles of ethics. What is non-maleficence?
That do no harm. That's my slide.
Okay. So give me an example.
I will not give the patient the wrong medication.
Okay, you're not going to give the patient the wrong medication. So give me two ways that we can prevent that from happening.
Make sure I got the right patient,
Okay.
right prescription. I'm giving them the right dose, the right route.
All
If I
right.
right.
Right. So you can follow the 9 rights of medication administration, right? And you can do your 3 checks, right? So that would be 2 ways of, doing no harm. Okay. What is beneficence?
You want to help your patients in the best of your ability.
Okay. So yeah, you're doing good, right? It means putting the client's interest first, right? This goes back to when I said if you give them the wrong medication, what is the first thing that we do, right? You report it, you check your patient, right? Make sure that your patient is stable, you do your reporting. It's putting the client before our own needs. Autonomy, right? Free to choose. So the role of privacy and autonomy, right? Remember, privacy is both a legal as well as an ethical issue. All right. And so when we look at autonomy, right, they have the right to make decisions about their health care, right? As long as they can think through all the facts, decide on, and part of an independent thinking process, they can act based on a personal decision, right, without any kind of pressure from anybody else. How does privacy oh my gosh, how does privacy fall under autonomy? I know it's Monday, guys. So privacy, right, we know that is both a legal and ethical issue, right? And so how, maintaining privacy, it's right, it's the right to choose care based on their beliefs, their feelings, their attitudes, right? It includes the client's right to decide what is done to their body, right? Accepting or rejecting treatment, right? And that's how it falls under autonomy. We have to respect their right, even if, their right to choose, even if it isn't something that we agree with. Fidelity means to be true, right? So, not talking about your clients where other people can hear you. You don't ever mention them by any, by name or, even a disease process or any kind of specific characteristics, right? It is not talking about them in the elevator, the lunchroom. It's also if we hear other nurses talking bad about our clients, right, that we stop that as well, right? It should be, it should not be allowed. And then justice means fair to all, right? So you're delivering fair and equal treatment to all your clients. You're recognizing and you're avoiding any personal biases when it comes to caring for your clients. Negligence, we've heard of negligence before. There are 4 parts that are needed to prove negligence. And so duty, breach of duty, damages, and proximate cause. So duty means that you had a duty to that client, right? That you had a responsibility to provide some sort of care to that client. And in the process of that, you breached that duty. You didn't provide whatever care, that you were supposed to, you were supposed to provide, whether it was an act of omission or an act of commission. So an act of omission, what was supposed to be done wasn't done. And an act of commission is what was supposed to be done was done, but it was done incorrectly. And then remember, your nurse experts are the ones that establish that standard of care. Damages, right? The client has to prove that the nurse's negligent act either injured them in some way, and they have to be able to prove that actual damage. And then proximate cause means that there was a cause and effect relationship, whether the nurse did the act of commission or the act of omission, either one is what led to the harm to that client. So Mrs. Stone is recovering from pneumonia, has been receiving steroid and antibiotic therapy. She has an indwelling catheter that was placed 4 days ago. Although being afebrile for 24 hours, this morning her temperature is 99.9 degrees Fahrenheit. What are your concerns, and what are 3 things that you can delegate to a nursing assistant? So look at this first. We have Mrs. Stone recovering from pneumonia. She's been receiving steroids and antibiotic therapy. She has an indwelling catheter that was placed 4 days ago, and now she has a temperature of 99.9. What are your concerns with Mrs. Stone?
She's running a slight fever.
Okay, she's got an elevated temperature.
So because she has a Foley catheter, she probably has an infection.
Okay, she has a Foley catheter. Tell me about steroids.
Do they increase your temperature?
Steroids weaken the immune system.
Okay, so steroids can weaken the immune system. Absolutely. All right, so let's see. So she's recovering from pneumonia. She's receiving steroid and antibiotic therapy. She has a catheter that was placed. And after, being afebrile, now she has that elevated temperature. So good job with that. All right, so what are some of the things that we could do? We'll have the UAP do ambulation, right? She's got pneumonia. What do we want to do? Do we want her laying in bed? No, what happens if I lay in bed where my secretions just pool, right? Um, they can get vital signs. They can give her a bath. They can empty that Foley catheter. They can reposition. They can assist with feeding if necessary. Things that we do not delegate to a UAP. We already know assessment, right? Can't CNAs, UAPs cannot assess. They're not going to communicate with the physician. They cannot provide reinforcement of education. They cannot give medications, and they don't do sterile technique, right? So what are some areas of education the LPN should reinforce with Mrs. Stone concerning pneumonia? So coughing and deep breathing, right? The deep breathing and coughing, right? We want to get any secretions, we want to get them up, we want to get them moving, get them out. Alternating rest and activity, right? So she is sick, right? For one, she's got an elevated temperature and she has pneumonia. She may have some shortness of breath, right? So we want to alternate periods of activity with periods of rest. We can give her an incentive spirometer. How to use an incentive spirometer? Just trying to find mine. I have one, but I don't know where. Oh, here we go. Incentive spirometer. How do we use this? Do I blow? Nope. So what do I have to do?
You want to inhale it,
I want to inhale.
and you want to teach a client to do it as many times as they want. What if they're sitting down, like watching television? Tell them to do it when the commercials come on.
Yep. Right. So COVID and the flu didn't totally kill my lungs. I can still use my in-center spirometer. All right. So yes. So we usually tell them when a commercial comes on the TV, right? It's a really good time to do it, right? It helps them to remember, right? Oh, a commercial's on. What was I supposed to do during that commercial? right? So that's an excellent way to do it. We can also want to teach her some, how is pneumonia transmitted, right? It's really noisy. You get it back in the box. How, what are some ways that we can prevent virus transmission with pneumonia? How do we prevent transmission? This can't get, won't go back.
Hand washing.
Clean.
Hand washing. Yes. What else can we do? Achoo.
Sneeze in your arm. You want to make sure that they're disinfecting their area.
Okay.
Whatnot.
So sneeze
Throwing
into their
away.
elbow, right? Sneeze
Yes.
into their elbow. If they use a
Discarding
tissue,
their tissue, throwing it away.
putting it in the
Don't leave your
trash.
sputum around. Nobody want to touch that.
Yep. Take all their medication as directed, right? We don't stop taking the medication when we feel better, right? And then she's also on steroids, right? Do we want her just stopping those steroids abruptly? No, right? So want to make sure that she knows that to stop those, right? You're going, what else? Plenty of fluids, right? Increasing fluids that helps to decrease the viscosity of the secretions, right? So that that can help to clear them out. All right. Rights of delegation. All right. Not that we haven't heard these before. All right. So we have the right task or the right circumstance, the right person, the right directions and communication, the right supervision, and the right valuation. Right. So making sure that we are giving them the right thing to do, right? We're not going to go tell the UAP to assess the patient's wound, right? So we want to make sure we got that covered. Then we want to make sure that the patient is stable, right? So we want to go do that assessment before we delegate any duties to our UAP, making sure that we are delegating to the right person, right? So you get to know your UAPs, their strengths and their weaknesses. You want to make sure that you give clear, concise directions, right? What to report back. And you want to be available for them should they have any questions. And then, go back and make sure that the task was completed appropriately. All right. Which of these assessment findings indicate a positive expected response in a 35-year-old client recovering from pneumonia? So which of these would be a positive expected response? So temperature changes from 98.4 to 99.8, a heart rate change from 102 to 110, SaO2 change from 92 to 95. Urine output changes from 42 to 110 mLs per hour. Client disoriented to time. Crackles decrease. JVD increases. Irregular heartbeats increase. Edema changes from 3 to 4 plus. Blood glucose levels spike. Potassium levels change from 4.9 to 4.5, and creatinine levels change from 2.4 to 1.5. So what would we want? What are expected outcomes in a client with pneumonia? Positive.
Three,
Three,
six,
4, 6,
3, 4, 6.
11.
All right. So 3, 4, 6, and 11. Anybody else have any others?
12.
And 12. All right. So 3, 4, 3, 4, 6, 11, and 12. All right. So 3, SaO2 from 92 to 95. Absolutely. Right. we're, getting those oxygen levels up. Urine output changed from 42 mLs to 110 mLs per hour. Does it have anything to do with pneumonia? Crackles decrease, absolutely. And then, of course, the potassium and the creatinine levels change as well. So yeah, urine output, the from 42 to 110 and oh my gosh, 42 to 110 mL, urine output shouldn't change. It shouldn't be much. That's not going to be one of the expected outcomes that we would see in somebody that has pneumonia. But the other one's correct, right? Your SaO2, your crackles decrease, your potassium and your creatinine levels. All right. A client has been taking antibiotics for 3 days to treat pyelonephritis. Which finding requires the nurse's immediate attention? So pyelonephritis, taking antibiotics for 3 days. Which finding requires the nurse's immediate attention? Anorexia, fever, cloudy urine, or nausea?
2.
All right.
I say fever
Absolutely.
too, Matthew.
Why? Why is a fever of a concern after 3 days on antibiotic?
Because a rising temperature is showing that maybe some type of infection is going on.
Potential infection.
Right. They already have pyelonephritis, right? They're on antibiotics, right? They shouldn't be spiking a temperature, right? Something else is going on, whether they have another infection or maybe the antibiotic isn't effective to treat the pyelonephritis. All right. The nurse reviews the teaching plan in the electronic health record for a client using epoetin alpha for end-stage renal disease. The nurse would question what part of the teaching plan. Monitor iron and hematocrit levels on a regular basis, avoid large crowds and fresh fruits and vegetables, monitor blood pressure, or call 911 with chest pain or shortness of breath. What's epoetin alpha?
A medication, it increases your red blood cell count.
Yep. It's the synthetic form of erythropoietin, right? Which is what is needed to make red blood cells. So which one would we question?
Two.
Yep. Avoid large crowds and fresh fruits and vegetables. Right. So again, epoetin alpha increases red blood cell production and allows for higher quality of life and increased dose and duration of chemotherapy. Treatment is not without side effects, right? MI, thromboembolic disease, client's blood pressure and hematocrit, in addition to iron levels, need to be monitored. Medication is given by subcutaneous injection, not orally. Activity restrictions and protective isolation are not indicated with epoetin alpha because again, it's working just on the red blood cells. All right. An LVN, I'm sorry, LVN is assigned to perform assessments on 2 patients with diabetes. Assessment reveals all of these findings. Which finding would the RN instruct the LPN to report immediately? Finger stick glucose reading of 185 milligrams per deciliter, numbness and tingling in both feet, profuse perspiration, or a bunion on the left great toe. Sorry. 2
3.
patients with diabetes. Which one of those assessment findings is going to be the most significant?
3.
I got a 3. Anybody else? So tell me about, is a finger stick glucose of 185 anything to worry about?
No.
Okay. Numbness and tingling in both feet. Is that something that we need to worry about?
No, because that could be expected.
Is numbness and tingling ever an expected?
No, it's not expected.
What is it a sign of?
Neuropathy.
Peripheral neuropathy.
Neuropathy.
Neuropathy, right? It's not expected, right? What is our goal with diabetic care, right? Is to keep those glucose levels, right, within our under tight, we want to try to maintain tight glycemic control with our diabetics to try to prevent, right? Some of those some of that end organ damage that can occur with the micro and the macrovascular complications, right? What is this?
Hypoglycemia.
A hypoglycemia. So we had two patients with diabetes. Okay. So it didn't tell you which patients. You could have had these two. This could have been one patient and this could have been the second patient, or you could have had any combination. But it's super important to be able to recognize. Okay. Somebody did say perspiration. Who said perspiration? Right? Tiffany did, right? But recognizing that, even so, I wanted to point this out because this is not something that it's not an expected finding. Okay. So profuse perspiration, I'm sorry, is a sign of hypoglycemia, right? So we would have to do something if they had profuse. But remember, this isn't normal. It's not expected. It can occur, okay, but it's not expected. All of the following nursing care activities are included in the care plan for a 78-year-old man with Parkinson's disease who has been referred to the home health agency. Which activities will the LPN delegate to the UAP? This one is a select all that applies. So recording blood or pulse and blood pressure measurements, assess for improvement in tremor after levodopa is given, reminding the client to allow adequate time for meals, monitoring for signs of toxic reactions to anti-Parkinson medications, or assisting clients with prescribed strengthening exercises. Select all that apply. What can the UAP do? Can they take blood pressure? Can they do vital
1,
signs? Okay.
3, and 5.
1, reminding the client to allow adequate time for meals and assisting with strengthening exercises. Absolutely. Can definitely do the blood or the vital signs. Remind the client to allow adequate time for meals and assist the client with strengthening exercises, right? No assessing, no monitoring. All right, a 23-year-old, so sorry, a 23-year-old client with a recent history of encephalitis is admitted to the medical unit with new onset generalized tonic-clonic seizures. Okay, so 23-year-old encephalitis, tonic-clonic seizures. Which nursing actions included in the client's care will be best to assign to an LPN whom the nurse is supervising? Select all that apply. So observe and document the onset and duration of any seizure activity. Administer phenytoin 200 milligrams by mouth 3 times a day. Teach the client about the need for frequent tooth brushing and flossing. Develop a discharge plan that includes referral to the Epilepsy Foundation. assess for adverse effects caused by new anti-seizure medications, and turning the client to his or her side to avoid aspiration. So what can be assigned to the LPN? Can you observe and document the onset and duration of any seizure activity? Okay. Can you administer medications? Can you teach the client about the need for frequent toothbrushing and flossing? Can you develop a discharge plan that includes referrals to the Epilepsy Foundation? Can we assess for adverse effects caused by new anti-seizure medications? Can we turn them to the side to avoid aspiration? Do that, right? All right. So yes, we can observe and document the onset and duration of any seizure activity. We can administer phenytoin 200 milligrams by mouth 3 times a day, and we can turn the client to his or her side to avoid aspiration. Right? Can't do new teaching. Right? We develop the discharge plan is done by the RN. Right? We can collaborate with that. Right, but we can't develop the discharge plan. Assess for adverse effects caused by new anti-seizure medications. Okay, so administration of medications is included in your scope of practice. Teaching, discharge planning, assessment for adverse effects are activities that require RNs. All right, the nurse is working with an experienced UAP and an LPN on the telemetry unit. A client who had an acute MI 3 days ago has been reporting fatigue and chest discomfort when ambulating. Which nursing activity included in the care plan is best assigned to the LPN or LVN? So 1, administering nitroglycerin 0.4 milligrams sublingually if chest discomfort occurs during client activities. 2, collecting pulse, blood pressure, and O2 sats before and after client ambulation. 3, teaching the client energy conservation techniques to decrease myocardial oxygen demand. Or 4, explaining the rationale for alternating rest periods with exercise to the client and family. So which one of those can the LPN do?
I'm thinking 2.
Oops.
1.
Administer nitroglycerin 0.4 milligrams sublingually if chest discomfort occurs during client activity. Right, so it is medication administration. All right, a client whose systolic blood pressure is always higher than 140 millimeters of mercury in the clinic tells the LPN, my blood pressure at home is always fine. What action should the nurse take next? 1, instruct the client about the effects of untreated high blood pressure on the cardiovascular and cerebrovascular systems. 2, educate the client about lifestyle changes such as low sodium diet, daily exercise, and restricting alcohol use to no more than 2 beers per day. 3, ask the client to obtain blood pressures twice daily with an automatic blood pressure cuff at home and bring the results to the clinic in a week. Or 4, provide the client with a handout describing the various types of antihypertensive medications with the medication effects and adverse effects. What does this sound like?
White coat syndrome.
Yeah, white coat hypertension. So what should we tell our client? Sorry.
3.
Very good. Ask the client to obtain blood pressures twice daily with automatic blood pressure cuff at home and bring the results to the clinic. All right. For a patient with hyperthyroidism, which task should the nurse delegate to an experienced UAP? Instructing the patient to report any occurrence of palpitations, dyspnea, vertigo, or chest pain. Obtain the pulse, blood pressure, and temperature every 4 hours. Drawing blood to measure levels of thyroid stimulating hormone, triiodothyronine and thyroxine, or 4. Teaching the patient about side effects of the drug propylthiouracil.
Two.
Very good. Obtaining vital signs, right? Good job. All right. Any questions?